Welcome to the Cancer Informant podcast, episode 4. I'm Dr. Tony Magliocco, a pathologist and cancer expert with many years' experience, and I'm the Cancer Informant. I'm here to share my experience with you, cancer patients and their loved ones, to help give insights about what to expect on the cancer journey, and also give my impression and opinions on how you might improve your outcome if you're faced with a dreaded diagnosis of cancer. In the previous episodes, we talked about several things: the role of a pathologist, how a second opinion might be useful, what sort of tests might be necessary to guide therapy. Today, we're going to talk about what happens next. What happens to a patient who does have a diagnosis of cancer? What might they expect? Perhaps this has been discussed with the patient from their care providers, and it's important that they do always go back to their primary care provider and oncologist to really get information about what is happening with their treatment. But I will give you some insights in general about what might happen with different kinds of cancers and why these treatment approaches might be used and why they might be different from one type of cancer to another. So typically, the encounter with cancer begins with the first discovery that a cancer has arisen or has occurred in a patient. So perhaps the cancer was discovered on a screening exam. If we take breast cancer, for example, a mammography might have found a lesion or an abnormality, and then a tissue core biopsy has been done and confirmed the diagnosis. At this point, the surgeon and the oncologist will have the information, yes, this is a cancer, and hopefully also the additional information about what is the biomarker status, because this is quite important in planning the treatment steps. Generally, the first line of therapy for cancer is surgery, and in most cancers, a surgical approach is considered. So if a cancer is small, the best chance to cure a cancer is to surgically excise it in completion, meaning completely remove that tumor, get it away from the body, and really cure it with surgery. So if a cancer is small enough, this can be feasible, and this is certainly the general approach in stage 1 cancers or early stage cancers that have not invaded a lot of the local tissues or spread to other locations in the body. So surgery might be the first step. This is indicated in breast cancers, in melanoma, even in brain tumors and other types of tumors, colon cancer, where surgical excision is considered. This might be the path that is first offered to a patient. Surgery is also important in that it must be complete. So if a surgery is embarked on, the goal of the surgeon is, can they remove that tumor in its entirety without damaging adjacent structures? Some of those structures might be quite important. They could be nerves, they could be major blood vessels. So a surgeon has to assess, can a tumor be safely removed, and can it be removed completely? Because doing an incomplete excision of a tumor is generally not helpful. If tumor is left behind, it will regrow and perhaps even be worse than the original tumor. So a surgical approach is the first thing that's generally considered. Now, if a tumor is large, several centimeters across, or if it is involving or near vital structures like nerves and arteries, a type of therapy might be considered called neoadjuvant therapy. And neoadjuvant therapy is an effort to apply external therapy to a tumor to try to shrink it down to a point where it can actually be removed surgically. So a period of chemotherapy or endocrine therapy or HER2, really depending on the tumor, plus or minus radiation may be utilized to shrink a tumor. And so once this therapy has been completed, then a surgery is done to remove the residual tumor. This neoadjuvant therapy is quite important. First of all, you want to make sure you have the correct neoadjuvant therapy. So that goes back to one of the earlier episodes, ensuring that actually the diagnosis of the cancer is complete and accurate, and that we also know what biomarkers are present in the tumor so that we can select therapy that is appropriate for that particular type of cancer. So once the neoadjuvant therapy is completed and surgery is done, again, the pathologist takes a prominent role. So the role of the pathologist in neoadjuvant therapy is to assess, did the tumor actually respond to the therapy? Did the tumor shrink? Is it removed? Are the lymph nodes clean? Is there evidence that there was tumor there and it's gone away? So this is an assessment of how sensitive is a cancer to the neoadjuvant therapy. The optimal outcome is something called a PCR, or a pathologic complete response. And if a patient experiences a pathologic complete response, this is fantastic news. It means that the patient has responded complete 100% to the therapy, and now there's no evidence of any residual cancer, and this is great news. Another outcome might be a partial response, and this can be problematic. So now a pathologist needs to assess the tumor, restage it, and often there's a little marking called Y that's put in front of the staging, indicating that this is a post-neoadjuvant evaluation. And generally it's considered a worse prognosis if there is residual cancer. It's also cause for concern in that if the cancer is resistant to the neoadjuvant therapy, that this choice of therapy may not be optimal for follow-up or continuance, and that the oncologist has to potentially reconsider how to manage a patient. So this is, again, an important step. The other thing to note is that if a patient has a pathologic complete response, that there is now no tissue left to test again. So this goes back to the first diagnosis, that is now the only specimen that's available for molecular analysis. This can be fine if that first diagnosis is large, but often the first diagnostic biospecimen might actually be quite small. It might be a core needle biopsy. It might only be a few millimeters in size, and it might be used up to make the diagnosis, and there might be none of it left if additional molecular analysis needs to be done. And this can really put a patient in a quandary in that molecular information is lacking, the tumor has responded, there's no residual tumor. What's a patient and their team to do? One of the options in this situation is that a liquid biopsy could actually be helpful. A liquid biopsy can be performed where a blood sample is taken, and then from the blood sample, we can actually examine it to determine if there are any circulating malignant tumor cells, or if there's any cell-free DNA that's coming from dying tumor cells. So this information tells us a few things. First of all, is there any cancer left in the patient's body following the surgery? So having a negative result is usually a good sign, indicating that there is no detectable residual cancer. If the result is positive, this can be a cause for concern because it does tell us that there is actually residual cancer present, although it is an opportunity for us to evaluate that residual cancer to determine does it have certain biomarkers that can help us select new types of targeted therapy for a patient. Also, cancer is tricky. Cancers are heterogeneous, meaning that if you look at different parts of the cancer, they may show different features. Also, cancers can evolve over time. They may initially be, for example, in breast, HER2 negative, and they may actually turn into a HER2 positive cancer when they metastasize. And this change may open up opportunities for more treatment. So that this could be quite important as well. It's also important to know that new treatments are coming along all the time. So for example, in women with breast cancer, Normally, they would not be treated with an anti-HER2 agent if they had scored 1 or 2 plus, which was generally considered to be HER2 low expression and likely to non-respond to classical HER2 therapy. However, in the last couple of weeks, there's been new publications have come out about a new therapy called Enhertu, which is actually a HER2 conjugated therapy where an anti-HER2 antibody is chemically linked to a topoisomerase 1 inhibitor, and then it acts like a magic bullet where it can deliver that highly toxic topo 1 inhibitor to cancers using the antibody to HER2 to guide it. Even tumors that have low HER2, the antibody will accumulate in them and the topo 1 drug will be delivered. And when it kills a cancer cell, it's also thought that drug will be released to a bystander cell and kill additional cancer cells that are nearby. This has been a great improvement in options for cancer patients, particularly women with HER2 low breast cancer. And actually about 50% of women have HER2 low breast cancer. And if they go on to metastatic disease and progression, there is very little therapeutic options available for them. With this new data from the Destiny-4 study, these women might now be eligible for treatment with the combination or the new antibody conjugate drug in HER2, which could be used and has been shown to be effective in effectively doubling the progression-free survival in these women. A very exciting step in terms of looking at that. So liquid biopsy could be useful. Now, there are some other tumors that are kind of interesting in terms of the treatment approach. So if we look at, for example, cervical cancer. In advanced cervical cancer, it's generally considered a non-surgical disease. So this is stage 3, late stage 2 cervical cancer, where it's actually treated with external radiation, internal radiation, and a combination of chemo and immune therapy. So some tumors can be completely eradicated without surgery, where if we apply radiation treatment to them and a combination of chemotherapy and immune therapy, those tumors can be effectively cured. There are several tumors like that, so cervical cancer is a good example. There are others in the head and neck and other organs that can actually be treated in this way. Going back to what can a patient expect? So first of all, surgery, they can expect to have surgery to have complete excision if it's a surgical case. They can expect to maybe have neoadjuvant therapy to shrink the tumor, in breast cancer to make it smaller. Other tumors where it's really important are pancreatic cancers. One of the problems with pancreatic cancer is that large tumors can be very near very important blood vessels like the inferior vena cava or the aorta or other important structures. And if the tumor responds very well to neoadjuvant therapy, it can shrink it down so it can now be safely removed without injuring those important other organs. So having neoadjuvant therapy and excision is something some patients might expect. Another might be having in situ treatment of the tumor using radiotherapy. So if tumor is considered non-surgical, it can actually be treated with curative intent, meaning it can be cured using radiation and certain types of chemo and immune therapy without surgically removing it. Patients who have stage 4 disease, so these are patients where the cancer is spread to other organs, so for example to the lung or liver or brain. These are generally considered non-surgical because it's almost impossible to remove those tiny metastases in all of those different organs. And a patient will then be treated with systemic therapy. And generally systemic therapy, if we go back to breast, would be therapies like estrogen receptor therapy, anti-HER2 therapy, immune therapy. These are all types of systemic therapy and are utilized in patients who have advanced cancers. So these therapies can be very effective, and in fact, the metastatic lesions may respond extremely well and disappear. If a patient has a low number of metastases, like 1 or 2, this is called oligometastatic disease, or few metastases, and these can actually be occasionally surgically excised. So in colon cancer, if there's only 1 or 2 metastatic lesions in the liver, it's now common practice to surgically remove those metastases. And if a patient has less than 5 of them, they tend to do extremely well. If there's a lot of them, again, it's very hard to remove those surgically. But if there's only a few of those can be removed surgically. If it's hard to remove them surgically, they can also be treated with targeted radiotherapy. And targeted radiotherapy is almost like doing surgery, that we can now deliver with great accuracy very high doses of toxic radiation to a tumor nodule and really kill it while preserving the surrounding normal tissue. So this is something that is now feasible and can be utilized. Another type of therapy that's now available is basically radiopharmaceuticals. And in this is where a tracer agent is labeled with a radioisotope, most commonly lutetium. And there's a drug that targets prostate cancer that's metastasized. And this radioactive tracer can be delivered to a patient. It can be used for imaging, so you can give it to a patient and then do a bone scan or a PET and localize where those radioactive targets have localized to tell us if there's a metastatic disease, but also at the same time treat those radioactive diseases because the lutetium is toxic to those cells. So not only do they label them, but they kill them. So this is a combination therapy called a theranostic, where both basically therapeutic, where it's both an imaging agent and a therapeutic agent. One other category of therapy I want to talk about is adjuvant therapy. So this is given to women who generally have early stage disease with breast cancer and certain other types of tumors as well, colon cancer, etc. And what it means is that we believe that we've probably removed the bulk of the disease surgically, but we're not certain that there could be residual metastatic disease hiding in the bone marrow or in the liver or in the brain. And we know through extensive evidence that women who are treated, who have this possibility of extensive hidden disease, usually these are women who may have high-grade cancers or positive lymph nodes or are younger, that they benefit from adjuvant therapy. So they may be given anti-estrogen therapy that lasts anywhere from 5 to 10 years, or other types of adjuvant therapy, such as anti-HER2 therapy, etc., which can be quite useful to control that hidden metastatic disease and delay or prevent the onset of emergence of metastatic lesions. So this is really a brief overview of some of the things that are possible and some of the types of treatment options that you might encounter. Sometimes a doctor or patient actually has a choice in what types of therapies they want to consider. For example, in breast, they may want to have a mastectomy. It may be an option versus a lumpectomy with radiotherapy. They may or may not need adjuvant therapy. They may or may not need chemotherapy. Often there are choices that are there to be made, and it's based on evaluating the odds of what difference does it make. Is there toxicity? Can a patient tolerate the treatment? Are there molecular findings that can help guide us? Are there blood tests that can help tell us whether a patient needs extra therapy and what kind of therapy there are? This area of selecting therapies and targeting therapies is in constant change. And it's a topic that we will continue to revisit during the podcast series and also select topics from this area to discuss in greater depth. So this concludes today's podcast about what sorts of treatment might a patient expect going forward. I hope you found it useful. Please leave any comments or questions you have on our website, and we'd love to discuss those in potentially future podcasts. Thank you for joining us today. I'm the Cancer Informant, and I hope you have a wonderful day. Take care.